got pregnant and planned to have kids, I just kind of assumed that birth would happen. And then I learned a little bit more and realized that the experience could be really varied.
You look at some of these C-section rates in some of these hospitals and they're in the 30–40%. And there's no reason that 30 or 40% of babies are medically necessary to be delivered by cesarean.
In my research, I put a statistic up pretty often that says, 50% of automotive repairs are unnecessary. And people believe that. But when I tell my academic audiences that doctors prescribe unnecessary surgeries very often, that nobody wants to believe it. Nobody wants to believe that's possible, that surgeries are happening and they don't need to, and it's unnecessary healthcare.
If you know that there's a certain, I hate to say it, financial incentive to keep operations flowing, and those finances are easily obtained through a service, you're more likely to promote that service. With that being said, the reimbursement for surgical birth to the hospital is pretty significant. VBAC stands for vaginal birth after cesarean. So if a mother has had a cesarean delivery, she is now attempting to have a vaginal birth after having that cesarean. The emphasis when I was training was to not do a repeat cesarean automatically, but actually to do a trial of labor and hopefully help that mom have a VBAC. The American College of Obstetrics and Gynecology, our college of our specialty, supports offering mothers VBAC.
I had a cesarean because of a suspected big baby. Having him, the first thing the doctor said, oh, he's not that big. And there's that, that immediate just, what did I do? I ended up having the C-section. I ended up very, very sick after the C-section. Max ended up in the NICU for about 9 hours. He had some fluid on the outside of his lungs, which we learned is because he was never birthed.
With every cesarean section that a mom has, there's a risk for bowel injury, there's a risk for bladder injury, there's risk of infection because of poor wound healing, because when you cause scars, the blood vessels don't flow through that too well. So on repeat surgery, that tissue may not heal as well, so there's risk of wound breakdown, and the list goes on.
When I found out I was pregnant, I first started that list of calling to say, are you willing to take a VBAC patient on? I got a lot of no's, and I got a yes.
Mama!
Hi, baby.
At 36 weeks, when I went to the doctor, just for my weekly check, then he started talking about, well, we need to schedule the C-section.
Yes, it's hot. Here.
If a mom is going to a provider to get that VBAC support throughout her pregnancy, then as she gets towards the end, if you will, there are certain things that are now being suggested by the provider to infer that VBAC may not be a good idea. Those inferences become more direct and more deliberate, such that they are coercive. And you get the answer you want, which means you're going to force the mother to have a repeat C-section by saying certain things.
At 40 weeks, then I went in for my, my weekly appointment. And at the appointment, I went up to get my appointment for my non-stress test. And instead, I had found out that my doctor had scheduled my repeat C-section without my consent. I think I probably called about 8 practices. Out of the 7, they were dead. Nope, you're too late. No, you're too late. At 40 weeks, 2 days, I had a conversation and I had reached a doctor who practiced with St. Joe's, who was willing to take me on, who was willing to be supportive and, you know, and help me have a chance. And I remember that instant when she lifted him out and put him on and she said, "You did it." And I said, "No, we did it." In my experience, that accessing VBAC in Maryland is difficult. You really have to have a team that's going to support you. You know, and it's not only that doctor, because that doctor has to have the hospital staff that's also supportive of it. You really have to fight for what you want if you want to have a VBAC in Maryland.
I'm a graduate student. I'm in my 5th year of a PhD program at the University of Maryland Business School in Information Systems. Here in Maryland, for me and my midwives, there's no question. I would be better off with them. And you know, if we needed to, we'd go to the hospital, and that's what happened in my first birth. But if everything goes fine, I was definitely safest at home. I knew that I would be labeled the VBAC, so my first priority was to figure out, well, what does that mean to me? And I thought it was like some risky thing, VBAC.
The risks actually are quite low. When you know that the risk of a rupture, which is typically defined as separation of the uterine wall, that happening has about a 1 in 200 chance, 0.5%. Mind you, that's the same risk of a complication from performing an amniocentesis to check the baby's genetics. Now, the risk of something catastrophic happening is 1 in 1,000 uterine ruptures. You hear about it so much, you think it's an everyday occurrence. But then when you start to look at the numbers or ask seasoned obstetricians and even midwives, when's the last time they've seen one? And they got to almost literally scratch their head. And I'm talking about people who actually practice VBAC, not the ones who don't do it.
I chose to plan a VBAC because I thought it was safest and healthiest for myself and my baby. I almost want to not tell anybody that I had a home birth because it was just mine. It doesn't matter that it was at home. It was just ours. I had my baby in a really comfortable place with family and providers who made me feel safe and were there if something went wrong.
I think midwives are important to the labor process because they bring a sense of normalcy to that. They make the mothers feel that it wasn't something that was invented 60 years ago. I think medicine has done a great job of making women feel as if they are not part of the biologic system of procreation.
Midwives are important, especially in the US, because they practice evidence-based care of low-risk moms. I mean, there's meta-analyses that show that midwives have better outcomes than obstetricians in the US and internationally.
I like to look at it personally from the perspective of what does the science say about VBAC, period, no matter what the setting. So if the complication rate is low, what do you do to support that or to deal with the complication? Then if you put that in a home setting, okay, it happens 1 in 200 times. Catastrophic rupture, 1 in 1,000 ruptures. Same in the hospital. We support midwives who do home VBAC, absolutely. Absolutely. Because it's been shown in our experience to be safe. And when you have a supportive network in place, you don't take risks that are unnecessary.
I don't think most women choose for cesarean, but if they want to choose that direction, they should be able to, and if they want to choose a vaginal birth after cesarean, they should be able to. If they want to do it at home, they should be able to. The data show that the risks are comparable, So why take the choice away from the people who are affected the most by it, the mom and the family?